Dr. Slamak is going to take it away now with Merkel cell. And then just as a reminder, we've got some questions coming in, and we're going to do all the questions at the end after Dr. Slama. So keep them coming, and great job so far.
Great. Thanks so much. So you'll hear some similar themes from what you heard today from Dr. Muzaffar and Dr. Ketterpal as we talk about a different type of skin cancer, Merkel cell carcinoma. These are my disclosures. So just a brief overview, we're going to go into a little bit of the basics of Merkel cell, a little bit of the epidemiology and who it affects, how we do some of the initial management, how we integrate care with surgery and radiation oncology. And I am a medical oncologist, so my expertise is in giving drugs for more advanced stages of cancers. So we'll talk a lot about some of the advances in the newer immunotherapies, and you'll hear a lot of similar themes to what you've heard earlier with other types of skin cancer, and talk a little bit about some ongoing clinical trials that we hope will continue to improve outcomes for patients. So, the first question patients often ask me, of course, is, not only what is Merkel cell carcinoma, but what is a Merkel cell? And Merkel cells are actually a type of skin cell that live in the top layer of the skin, or the epidermis. It's believed because they were originally found near nerves, and it's now known that they're related to relaying touch or sensory information to the brain. They also produce certain hormones, but we don't really know all of their functions. But that's why you'll sometimes hear Merkel cell carcinoma referred to as a neuroendocrine carcinoma of the skin, or that a Merkel cell is a neuroendocrine cell. But for today, we'll continue to call it Merkel cell. It is a rare, potentially aggressive skin cancer. I've showed a representative sample here of what it might look like, but it often occurs as a painless lump on the skin that can often grow rapidly over weeks to months. And then to the right, you'll see a picture of what a Merkel cell looks like under the microscope, and that's how our pathologists help us make that diagnosis. When we look a little bit about Merkel cell and who gets it, so I mentioned it's a rare cancer. There are about 2,500 to 3,000 cases a year in the United States. But you can see here on the left that the incidence is on the rise, and this sort of tracks things over the past sort of 40 to 50 years or so. And the risk factors for Merkel cell are very similar to maybe what you've heard earlier tonight from my colleagues. So certainly age, we know, is a risk factor. It's actually very, very rare for patients under 50 to get a Merkel cell. It is certainly associated with sun exposure, so sun-exposed parts of the body, like the head and neck, the trunk, the arms. It can be, to some degree, associated with a suppressed immune system, although the vast majority of patients with Merkel cell don't have any clear immune suppression. And I think all these factors really kind of have rolled into one, because if you think about it, we have an aging population, and certainly for patients who may be over 65 or 70, we didn't know as much as we know now about sun protection, that advice from Dr. Ketterpal. So we have increasing numbers of patients who there just wasn't a general public awareness and education, perhaps earlier on, stressing the importance of sun protection, that puts these patients at a relative increased risk, and similar features that you've heard earlier, but having lighter skin, fairer skin type, of course, also put people at risk. So just because I'll be talking about something called the Merkel cell polyoma virus a little bit later, I just wanted to show a little bit of science here and talk about how we think Merkel cell carcinoma is formed. When we talk about mutations or DNA damage from UV radiation, this is a little bit of a schematic of what we're talking about. So you can see on the left-hand column, this is a cell DNA, and that exposure to ultraviolet light can cause alterations in that DNA, which we believe can lead to a cancer like Merkel cell. On the other hand, we also know that in fact, the majority of Merkel cells appear to be associated with something called a Merkel cell polyoma virus, which similarly can integrate into the DNA and cause DNA alterations that can lead to Merkel cell. I'll talk a little bit more about this later, but this can sometimes play into how we keep track and follow up patients after they've been diagnosed, whether their cancer is found to be associated with the polyoma virus or not. And then I'm always really important, though, to kind of point out, because another question we get asked when we start talking about genes and mutations, these are all genes that are in the tumor and the cancer cell or the cell in the patient's body. These are not genes that are inherited or passed on. So to the best of our knowledge, there's not really an inherited form of Merkel cell, but all of these appear to be really, spontaneous, kind of associated with the risk factors that I was describing earlier. So I'll do a brief overview of some of the initial management. And I think, the one theme I hope to highlight in my talk tonight, and I think, so lucky to be on with my colleagues who practice in a number of different specialties, because of the rarity of this cancer, again, contrasting with some other skin cancers, I really think, I'm biased, of course, but I really think evaluation at a center where surgeons and oncologists and radiation oncologists have Merkel cell expertise and partnership with dermatology. Again, because so much of what I'm talking about, again, it's impossible to give a defined treatment plan for any one patient. And so much of this really does depend on the specific clinical situation. Also a little bit different than many other skin cancers. Usually we get some type of imaging prior to proceeding with surgical excision, although every case varies a little bit. But because Merkel cell can be potentially aggressive, there's some patients where we note spread at the time of diagnosis, and that would change our treatment recommendation. So again, depending on the size and location, and again, just depending on the overall patient, imaging is something that is sometimes considered. The mainstay, like all other skin cancers we're talking about here, is often surgical excision. We haven't talked about it tonight, and certainly if there are questions about this procedure, Dr. Beasley will be available at the end, but talking about a sentinel lymph node biopsy is sometimes considered for patients. And I just provided a diagram of what that looks like. So that's where the surgeon actually, at the time of surgery, injects a radioactive substance with or without a blue dye into the tumor to detect the first draining lymph node. And they can detect that there, as you see, with a probe. And then they can remove those first draining lymph nodes. And that gives us a really good sense of whether the rest of the lymph nodes might be involved or not. And that's important as we think about the patient staging, which would have implications for additional treatment recommendations, such as radiation, again, which is decided as part of the team, as well as any additional therapy or trials that they might be eligible for after surgery. So when I started off, you heard me mention the Merkel cell polyoma virus, and I just wanted to give an example of how that can impact surveillance after surgery. So we think about half of all patients have antibodies to the polyoma virus who have been diagnosed with Merkel cell, that there's actually a test in the blood that we can send that out to a lab. And you can see here there's reasonable data to suggest that that can help us with surveillance and give us a sense of the state of their disease. So typically what we do, we would check this blood test around the time of surgery, either right before surgery or maybe right after, where we would expect it to still be positive for about half of patients. And if it is positive, we can actually follow it over time with a blood test. And what we ideally want to see is what you see with these 3 patient examples below. Each time point, each dot on the line is a blood draw time point. And you can see nicely after surgery that their polyoma viral titers actually went down to 0 or at least decreased. And these were patients who had no evidence of recurrence. And, we still don't know the perfect way to integrate this, but for some patients, for example, if they have a falling titer that stays negative, that might mean they need less frequent imaging studies, which, can be time consuming or add extra expense. And again, this is really something to discuss with your multidisciplinary care team. On the other hand, if we see after surgery, a patient really their titer doesn't go down all that much or starts to rise, even if scans are clear. Again, there's no perfect test, but that may also impact how we follow patients. So I can say that in my clinic, if we started seeing titers go down and then all of a sudden started seeing them go up again, we might bring that patient back in for more frequent or more intensive surveillance. But again, I think because this is a rare cancer and because each situation is unique, we're still really learning the best ways to integrate all of the new technologies that we have. This, I just wanted to show here as a reference as we talk about sort of staging and prognosis for Merkel cell. I will draw your attention to the date. This does not include the prognosis with some of the newer therapies that I'm going to talk about. But like many other cancers, we use staging to help us gauge prognosis, which then helps us gauge risk and benefit of various treatment approaches, because certainly if patients are highly likely to be cured by surgery alone, we don't really want to expose those patients to any extra risk or extra treatments. But for patients who have maybe a more advanced stage or poor prognosis, that's a time where it maybe makes sense to start thinking about some additional treatment options. And so we can see that, even for localized or early stage Merkel cell, you do have a number of patients that have a recurrence of their cancer, but certainly that increases with stage. And historically, going to be glad to talk about their differences now, of course, but historically, the prognosis for patients who couldn't have surgery or complete removal of their Merkel cell was actually quite poor. So you've already heard about this tonight, and it's a theme, and I think that's because it's really hard to overstate how much immunotherapy has really completely changed the landscape for so many cancers. So not just skin cancer, but many other types of cancer as well. But in Merkel cell, I would say it's shown particular promise. So this is just a diagram, again, to kind of review how these therapies work. But you can see here that normally a T cell might be quiet. You want your T cells, which are your main sort of immune cells, your kind of the cells that are involved in fighting infections, but also the cells that are involved in hopefully targeting things like cancer. And normally they need a couple of different signals to tell them to turn on. So they need to recognize something as being foreign, which theoretically you can see here would be a cancer cell, but they also need additional gas pedals, if you will, to kind of help them do their job. And what cancer cells really do is they kind of hijack the body's own normal protective mechanisms. And cancer cells have found a way to put a brake on our T cells. And you can see that it essentially puts that T cell to sleep. So the T cell really can't do its job anymore. And what's been so revolutionary about checkpoint inhibitors, this class of medications that we've all been talking about, is they really block that brake. And you can see that they then remove that brake and allow the T cell to become activated again and do the job that it was intended to do. So with that in mind, so I'll talk about pembrolizumab, which you've heard some about. So a PD-1 checkpoint inhibitor. and this is in patients with advanced Merkel cell carcinoma. So this was a study in about 50 patients who were all had not received prior treatment for their Merkel cell. And here you can see pretty dramatic benefit. This is something we call a waterfall plot, which basically each line is a patient. It didn't really seem to matter in this trial. The blue and the red is if the patients were virus positive versus virus negative. Each group of patients appeared to have benefit. But here what you can see is that the majority of patients clearly had benefit and shrinkage of their tumor. So that 0 bar is sort of their baseline. So when we see the waterfall going down, that means the tumors are shrinking. And when we see the waterfall kind of rising up there on that left-hand tail, that means the tumors were growing. And this, as an oncologist, is definitely the kind of waterfall plot you want to see. You want to see that the majority of patients are having tumor shrinkage. And in fact, a lot of patients are having quite a bit of tumor shrinkage. So those bars on the far right that go all the way down, that means those patients had complete disappearance of their cancer on imaging. So that's a first important feature. So PD-1 therapy results in high response rates, so high rates of shrinkage. But the next thing that we really think about is, well, how long does that last? Because it's great to shrink the tumors, but what we really want is we want that shrinkage to last. Ideally, we want it to be permanent. And so these types of graphs give us that kind of view. And so on the left, this is what's called a spider plot. And what I like to say is you really want this kind of plot to sort of all kind of trend downward, really look like an open umbrella, like a lopsided open umbrella, where lots of tumors are shrinking and then it's kind of continuing for a very long time. And you get that sense here because that the bottom x-axis is appears the responses are going on for months. And then you can see that in the right-hand column, or the right-hand graph, that this is the median duration of response that you can see for those patients who had a response to pembrolizumab, the median duration was not reached. So what that is telling us is that the majority of patients who get that initial shrinkage tend to maintain that shrinkage. And that's exactly what we hope to see with immunotherapy and results in long-term benefits for our patients. So this, just to give a sort of historic comparison, this is what we used to think as sort of the standard in Merkel cell. We used to give chemotherapy for this disease, and the median survival was about 9 months. And again, translated with pembrolizumab, you see median overall survival was not reached, again, with many months of follow-up. So again, that hope that patients do well, the patients who do well initially continue to do well for a long time. Just to be complete, I did want to mention another PD-1 pathway drug. This is a PD-L1 pathway drug called avelumab, which is also approved for Merkel cell. And I think this is important because it just highlights, and these were patients who had had previous treatment. In this case, it was largely chemotherapy. And the graph on the left overlays the curve of the avelumab arm. So you can see this tail of the curve. So while not everyone benefited, those that did appeared to do well. And these curves are historic chemotherapy trials. So you can see that the vast majority of patients, unfortunately, did not benefit long-term from treatment. And again, we saw similar benefit in terms of overall survival, that even with patients with prior therapy, which we often think can sometimes be harder to treat, the more lines of therapy a patient has received, the harder it is, the more work sort of the next line of therapy has to do. But again, even in previously treated Merkel cell, we saw that benefit. This is a swimmer plot, and again, it just really confirms what we saw in the first line patient. Each one of these are an individual patient, and you can see that the triangles and the green squares are patients when they had a response. You can sometimes see it takes a while to get that response. So sometimes we don't see that full response until several months after immunotherapy, which is a little bit different than other types of therapy. But you can see the majority of patients who initially benefited were maintaining that response. But certainly at the bottom here, not everyone. There were some patients who had some initial benefit, and then things started to grow again. This has already been mentioned, and I think Dr. Catterfall did a nice job of reviewing side effects. Certainly, it is always a risk-benefit discussion for our patients because, I've talked about all of the great benefits of immunotherapy, but we know immunotherapy can certainly have serious side effects, which is why we want to be cautious of when we use it and use it in the right situation for the right patient. So kind of switching gears to the next phase, we've said all these great things about anti-PD-1 therapy, which is really now the standard frontline treatment for Merkel cell. But if we are glass half empty, we acknowledge that still means about half of patients aren't benefiting from that first line therapy. And so one of the strategies has been, in addition to taking one break off of the immune system, to take a second break off with a drug called ipilimumab. This was a phase 2 trial that did include 2 different groups of patients. And the take-home point here was that the addition of radiation did not really add any additional benefit to the immunotherapy here. But it did show us that this 2-drug combination or dual checkpoint inhibition could sort of rescue some patients who had a prior growth on prior immunotherapy. So when we see that, we often ask the question, well, if it works in the second line, let's try it as frontline therapy. Maybe 2 is better than 1, which has actually been the case in some other skin cancers. And the take-home point here is that that was really not the case. You can see Nivo, which is another PD-1 drug, had a very high response rate for the frontline setting. And very similar to Ipi-Nivo. And so, while this trial, I think, was interesting, it really set home the point that it doesn't take two drugs in the first line setting. And we know that the toxicity is much higher with the 2-drug combination. And so that's why still for Merkel cell, the standard therapy is just one drug. I'll talk a little bit about here. Dr. Musavar already talked about neoadjuvant therapy, but the thought, if we give some immunotherapy before surgery, maybe we could do a better job of stimulating the immune system with the tumor still in place. So it gives more T cells that can kind of increase that chance of an immune response. And this has also been done in Merkel cell. So this was a small trial done for patients with resectable Merkel cell. They got 2 doses of immunotherapy prior to surgery. You can see this patient here had several large lymph nodes under their arm. And this is what it looked like after those 2 doses. You can see pretty dramatic shrinkage, and similar benefit was seen across the group. So this was, again, a waterfall plot of individual patients on that trial who had tumor shrinkage. And importantly, I'll draw your attention to what we call the pathologic complete response and the major pathologic response, that more than half of patients either had no tumor present, in pathology at the time of surgery, or only about 10% tumor that was still alive. And so that's really considered a really good prognostic sign for these patients. And you can see that correlates here. So for patients who have a complete pathologic response, it gives us an early signal that they're going to do really well. Looking forward to the future, this is a trial that we had open at Duke, where, again, trying to look at for those higher risk patients after surgery, does giving some additional immune therapy after surgery further reduce the risk of cancer recurrence? We don't actually know the answer to this yet. We hope to have results of this trial soon. But again, an example of how immunotherapy has been being integrated earlier and earlier in the management of Merkel cell. So this is just our summary. Certainly a rare skin cancer that certainly does have the potential to be aggressive, which is why we feel at Duke that seeking an opinion with an expert, seeking that multidisciplinary opinion is really important. And while certainly I'm really encouraged at all of the progress that's been made, I think still there's a lot of room to go for our patients. And this is where clinical trials, I think, can be so valuable. Thank you.